Hello, Rohini. Finally, nice to put a face to a name.
Agreed. It's so nice to see everybody. Good morning, good evening, and afternoon.
Hello, Batia. Everything is fine? Perfect. Great.
Donna, is the audience, do they come on board in a couple of minutes, or can anybody join right now?
I think anyone's joining right now.
And yeah, there's no, anybody can join at any time.
Okay. This sounds like most of the audience is non-medical, correct?
Yeah.
Yes.
Okay.
Hi, Silvia.
Hi, good morning. So I'm going to share my own slides, right?
You can do it as you want.
Yeah, no, I will share my slides.
Okay.
So, thank you.
It's 8. Should we begin?
Yeah, maybe it's a good idea. People will join in slowly, because different times on the globe.
Okay. Well, welcome to our panel, Disparities in Cancer Care for Women and Urgent Global Need. I'm Donna O'Brien, a member of the Board of Directors of the International Cancer Expert Corps, or ICEC. Each of our panel members has a connection to the ICEC, but each brings a different perspective on cancer and their work to address cancer disparities globally. The focus of our panel is on radiation therapy and women's cancers and why it is so essential for cancer treatment and the challenges of making it available. You'll hear from a chair of radiation oncology at an academic medical center, a radiation oncologist who works with the American Indian population, a radiation oncologist and researcher who works in Africa, and a radiation oncology resident who has also worked in Africa, as well as a PhD biologist with a long career in global health and radiation therapy, who has been a mentor to many students across the globe. Each panelist has had a long and impressive involvement in addressing cancer disparities. To set the stage, we're going to begin with a presentation by Dr. Silvia Formenti, who will be talking about the impact of women's cancers on families and children. Dr. Formenti is the chair of radiation oncology at Weill Cornell Medical College, Weill Cornell Medical Center in New York. She's a recognized leader in breast cancer research, and her groundbreaking work has transformed the paradigm in radiation biology, demonstrating the efficacy of combining radiotherapy and immunotherapy to control cancer cell growth in solid tumors. She is a champion of efforts to improve access to care for underserved populations, and her research includes studying the impact of cancer in women in LMICs and on families. She's a member of the board of directors of the International Cancer Expert Corps. Dr. Formenti.
Thank you, Donna. I'm going to, and thank you again for inviting me to this great panel. I'm going to share my screen. Okay. You see my slides well?
Yes.
Great, thank you. Good morning, I'm Silvia Formenti. I'm the chair of radiation oncology at Cornell. And this is what our hospital is a chain of hospitals in New York that drain both the Manhattan as well as the Bronx and Brooklyn and Queens, where we have enormous diversity of patients and needs. So it's a microcosm of the multi-ethnicity of the United States. So cancer is a leading cause of death in low-income countries. It kills more people than HIV, AIDS, malaria, and TB combined. So it is clearly a global problem. So the global cancer problem is, however, having a different burden in different countries and in different continents. So the global count of 2020 demonstrated 19.3 million cancer new cases worldwide, 10 million cancer deaths worldwide. When you look at the new cases of cancer, half of the new cancer occurs in developing regions, while those same regions account for nearly 2/3 of the cancer death. So as you can see, it's a disproportionate consequence of cancer. And we expect an increase of 70% from 2014 to 2035 of cancer, reaching 24 million in 2035. So a huge global problem. And when we look at women cancers, they're really different in terms of incidence and mortality, their prevalence in high income countries, nations versus low and middle income nations, while the incidence in wealthier countries are mostly breast, and the deaths are mostly associated with lung cancer. And second comes colorectal and lung for incidence, and breast and colorectal for mortality. When you look at low and middle income nations, breast is still the dominant primary cause of cancer as well as cause of death, but is followed as an incidence by cervix cancer, cancer of the uterine cervix, and then lung and respiratory tract. And then the mortality, you start seeing cervical cancer appearing among the cause of mortality. So once you combine breast and cervical cancer as cause of mortality, you can see that for female cancers, they are the main culprits. So what it really means is that every year, 2 million women worldwide are diagnosed with breast or cervical cancer. And in low and middle income countries, 7 out of 10 of the breast cancer death can be accounted. And in terms of cervical cancer, is really the prominence of death occurs in the low and middle income countries, with 9 out of 10 deaths occurring in those countries. So these are deaths that could be prevented by, of course, prevention in cervical cancer and treatment. And I'll show you in a minute how short we are on treatment. So the other very concerning aspect of this problem is that these women cancers occur earlier in the age of a woman. When you look at the different countries and different continents, and even in New York or in the United States, if you go to data for the United States, you can see that compared to Caucasian women, which is in the dark gray line, when you look at the incidence, the proportion of breast cancer diagnosed by age, you can see that in Hispanic, Asians, and Blacks, it occurs much earlier. And the same is even more prominent is for cervical cancer. So in US, the common age of incidence is 35 to 44 years old, is even younger in Africa and in Asia. And cervical cancer is common during a woman's reproductive year, so is breast cancer. And that has enormous implications. So we ask the question of whether we could understand the impact of dying of these cancers on children, on the children of these women, because women are most of the times are the primary caretaker of the children. And what happens once the mother dies? And there is quite a bit of literature from death from infectious disease. And you could proportionally imagine that death from cancer would have the similar impact. So we did a modeling kind of study and demonstrated that, in fact, when you project the impact of the mother dying of cancer on the likelihood of surviving this event in children younger than 10 years old, you will have that for every 100 women who die from either of these diseases, between 14 to 30 children will die as a result. So this is a collateral damage that must be taken into account when policies are formulated for the prevention and treatment of these diseases. And when you then look worldwide, the nations that come up as the main exposed nations are in fact in Africa. And you can determine with a certain level of accuracy what will be the exact impact. And as you can see, is mostly for Central Africa that you're going to see the highest impact. And it builds on the pre-existing high mortality for these children. So it's an incremental cause of potential death in children younger than 10. So it becomes a problem that goes far beyond the mortality of the woman and affects the children. If we measure the children, we didn't have the tools to measure the impact on the elderly, because often the woman is also taking care of elderly or sick people within the family. And here brings the role of radiation. So radiation plays an important role in general for in cancer. Half of patients with cancer really need radiotherapy to assure their best outcome, both cure and palliation of their symptoms. And the recommendation in general would be, a very well used one machine per 250,000 people, requiring not only the machine, but everything that sustains the activity of a radiotherapy center. And in the United States, we have an abundance of these machines, maybe in excess, with one machine every 105,000 people. That enables us to really accommodate the needs of our patients in general, much better, but you will hear there are also areas of underservice, even in the United States. So it needs to be really calculated and very carefully to assure access and coverage of all regions. And the difference is enormous in South America, where there is one machine per 640,000 people, but it becomes so dramatic in Africa, where there is one machine every 4.8 million people. So this is practically impossible to take care of cancer without these machines. Over the years, the technology, of course, and engineering has evolved dramatically from cobalt machines that present a lot of challenge, including handling of a highly radioactive material like cobalt. And it has evolved to linear accelerator, and we hear about the potential for machines that are really suited to fit the needs of developing countries later on in this session. But most importantly, the need that remains is that of assuring that the people who operate the machines are stable and well qualified and learn everything possible to optimize the use of those machines. And in this sense, ICEC has organized a really very functional partnership with the oncologists in these different countries and US radiation oncologists. And here showing our faculty, Rohini Balogun, who has really devoted her research to these issues, and together with the director of Marina Center, Munandulo in Gabon. And what she has developed is that based on research that we have conducted at Cornell, we demonstrated that, in fact, when you treat women lying on their back, the supine position, inevitably you include the entire breast, you include part of the lung and part of the breast, of the heart, and I can show you for the left side here. And that is an X-ray, reconstructed X-ray that shows the lung in brown and part of the heart to include the entire breast. But if you flip a woman and treat her lying on her stomach, you can very easily and reproducibly avoid the heart and the lung and just treat the breast. So there is significantly lower dose, and if, of course, sparing the heart and the lung prevents complications of radiation to these organs that could appear many years later, but certainly can even compromise the life of the patient. So Oni has dedicated her research to develop a curriculum, and here you can see that Oni that is teaching in Gabon and has developed a collaboration with the local doctors, therapists, and physicists. And I want just to stress that each of these interventions are really a reciprocal occasion of learning, whereby she has spent quite a little bit of time to understand what were the needs in Gabon, and then figure out with the people on site is a rational solution. Here you can see her in the physics laboratory in that department, and one of our therapists, Samantha, that went with her, is now as marking a volunteer patient to show how to treat on the prone position, and drastically change their practice by introducing this innovation that also accelerates the treatment. So this is just a tiny example, and of course, much more to come. And I'll stop here and welcome the next speaker. I think it's Dr. Petereit. Thank you.
Thank you, Silvia. I'd like to introduce Dr. Dan Petereit, who's a radiation oncologist at Monument Health in Rapid City, South Dakota. He's the founding director of the NCI-funded Walking Forward program in South Dakota, which serves the American Indian population on reservations in South Dakota. He's also served as president of the American Brachytherapy Society and championed global health programs through that role and others. He's a member of the board of directors of the Cancer Expert Corps. Dr. Petereit.
Hello, Dan, you're silent.
You can see your slides.
Yeah.
You can unclick presenter view right under where it says monitor if it's helpful.
There we go. Can you hear me? I had everything
Yes.
else set up.
Yes.
Okay. All right. Am I sharing my screen right now or not?
Yes.
Okay.
It's not full screen though for your
No.
slides.
No, I'll get there in just a second. I had all set to go except the mute. All right. How about now? Are we good?
Still
Yes.
not full screen.
Yeah, done.
Okay. How about this?
Perfect.
Okay. All right. Well, it's my pleasure to be with you at this early hour. My name is Dan Petereit. I'm a radiation oncologist in Rapid City, South Dakota, and we have a cancer disparity program called Walking Forward that I'll get into in a little bit. My objectives are discussed a little bit on Dr. Formenti has done a terrific job of discussing disparities in cervical cancer, so I'm not going to duplicate that much. But I really want to get into what our cancer disparity program Walking Forward is all about. And then I want to tie this in with how it relates to our radiation oncology initiatives, especially as a former president of the American Brachytherapy Society. I'll discuss an initiative that we have launched in the last 2 to 3 years, but we're finally have gone live in the last few months called 310. So although cervical cancer isn't that common in the US, and right now there's estimated to be 14,000 cases this year and about 4,200 deaths, it's much more prominent worldwide. It is a disease that you heard that affects younger women. It's the second most common cause of cancer death in women worldwide. Third cause of cancer death, it is a disease of a disadvantage. The human papillomavirus is a causative agent, and worldwide it's estimated that one woman will die from cervical cancer every 2 minutes. So it really is a cancer that affects a young population, the offspring, as you heard, and has devastating consequences. This is a terrific article that came out from Dr. Gaffney from the University of Utah that talked about in the Journal of Human Oncology entitled "Too Many Women Are Dying from Cervical Cancer, Problems and Solutions." He discussed this, and we see this in our own population that's affected by rural status, race, and ethnicity in the U.S. He discussed cervical cancer as, or poverty as a carcinogen, and what are some ways that we can address these issues in disparate populations. There's an emphasis today on worldwide populations, but my goal is to talk about what's happening in my part of the United States. We know that Pap smear saves lives. We know that detected early, the cure rates are very high. There's a vaccine for this. Since the implementation of Pap smear decades ago, you can see that the death rates from cervical cancer have gone down. But let me just transition to where I'm currently at. So if you don't know where Rapid City, South Dakota is, we are right in the middle of the US, just a little geography lesson there. Very remote compared to where Dr. Formenti lives, but we do serve a fairly wide area of about 400,000 patients within about a 5-state region. The area where we serve, so I live in the Black Hills of South Dakota. The Lakota Nation lives out here. They live on the reservations of Standing Rock, Cheyenne River, Rosebud, and Pine Ridge. And most of these patients seek their cancer care in Rapid City. When I moved here back in 1999, it became evident after working in the clinic for a year or two that the Native American, and I'll use these terms interchangeably, American Indian, Native American, and Lakota, but just from clinical experience, and I knew this when I relocated to my home state, is that when we were seeing patients in consultation, especially for screen detectable cancers, and this is borne out by our own tumor registry, is that we look at the Native American versus the non-Native American population. The overarching theme that we identified is that patients were presenting with more advanced stages of cancer. And so literally and figuratively hit the road to try to figure out why this is. So then there are areas, I'm going to go to this next slide in a bit. There are areas in the US, I must have deleted the slide, but it's called the Northern Plains. And so there's various areas within Indian Health Service regions, and the Northern Plains are up in this part of the US. Getting back to the previous slides here, for cervical cancer, we do see that the Northern Plains American Indians have some of the highest cancer incidence and death rates from all cancers, and especially screen detectable cancers. Lung cancer, they have the highest mortality rate from lung cancer in the US. Smoking is also a cofactor in the development of cervical cancer, so that's relevant. So what does life look like in Native America in these regions? So there's high rates of high-risk health behaviors and comorbidities. So there's social stressors. Historically, there have been low rates of screening that's been related to resources, trust, remoteness, health literacy. As a result, these patients do present with more advanced stages of cancer. They're more likely to receive cancer-directed therapies after cancer diagnosis than not Hispanic whites. In Pine Ridge, it's one of the largest Indian reservations in the US, with about 40,000 people. This is a relatively young population. Over half live below poverty, and they have some of the lowest life expectancies in the US. Median age of death is 48 for males and 52 for females. So there's something going on here. And it does relate to the fact that, using Dr. Gaffney's quote, that poverty is a carcinogen. So we put in this grant back in 2001. It was part of a grant from the National Cancer Institute called the Cancer Disparity Research Partnership. And this grant money was targeted for community cancer centers that serve disparate populations. So we were fortunate and we received this grant. The hypothesis initially to address disparities, again, the disparities here is that they present with more advanced stages of cancer. We're trying to determine why is that. And I'm not going to show much of this data, but a part of it was behavioral research, assessing barriers to early cancer detection, culturally appropriate community education. The most important part of our program is our patient navigation program that I'll discuss briefly. recruitment to clinical trials. As a radiation oncologist, because a lot of these patients live 2 to 3 hours from the cancer center, we developed shorter radiation schedules for prostate and breast cancer to try to address that issue of geographic distance from the cancer center, that potentially that could be really leading to advanced stages of disease. So the primary hypothesis was these interventions would lead to patients presenting with earlier stages of disease. A bit in our navigation program, we have 10 staff that work for us. The majority, probably the only male in the program is the PI. Majority are American Indian women that live in the reservations. We have 2 to 3 staff on each of the reservations, 3 in Rapid City because we have an urban population here. But they're really the core of who Walking Forward is. And there are, as I would call, boots on the ground, is promoting education, outreach, networking. Initially, during the first 5 years, we also had a cancer navigation program. We still do with the RNs. So when patients were diagnosed with cancer, they would help facilitate timely treatment. And then the second phase of Walking Forward, we had the community navigation program, our cancer navigators, and then we hired a cancer screening coordinator within each Indian Health Service hospital to try to shorten that time from onset of symptoms, diagnosis, and seeking treatment. We've done several analyses. We have been able to show there's been increased compliance rates for patients that have undergone navigation, which is really important for cervical and head and neck cancer, because treatment prolongation can be detrimental to their outcome. We've looked at the impact of navigation with compliance, or patient overall experience being enhanced, changing in trust towards the healthcare system. That's a tough one to change because there's a lot of historical trauma out here, and a lot of our educations have gone through what we call cultural competency training. So this is the road down to Pine Ridge. These aren't interstates going down there. This is one of our community events. We've had probably hundreds of these over the years. This was an interesting event that we did back in 2016, and the topic of cervical cancer as a brachytherapist is I'm very passionate about this, because most of the women we see from the reservation have very advanced stages of cancer. We did an innovative pilot study where we did these educational interventions where we brought women in. Only my female staff was allowed to be there, but it was a pre and post test survey after they did their intervention on knowledge and attitudes about HPV vaccines, and cervical cancer. There was an improvement in knowledge. They preferred vaginal self-testing. And interestingly, they were given the opportunity at the end of this educational event, because they could go into the bathroom and do a vaginal swab. 93 of 95% participants were interested. We had that test sent off for HPV analysis with groups that we'd work with. And one of the conclusions was that this HPV self-testing may be a strategy to improve cervical cancer screening rates, because we still have this problem ongoing with patients coming in my clinic have very advanced stages of cancer. We've coordinated about 4,000 screening, or helped facilitate screening of 4,000 patients. This is our vision and our mission to improve the quality of life for American cancer Indian patients of early detection, successful treatment, and survivorship, including end of life. And that we have currently a palliative care project. Our mission is this has been and will continue to be accomplished through access to screening, state-of-the-art cancer treatments and clinical trials, and comprehensive navigation. And I just want to spend a minute or two, because I know I'm running short in time here. So treatment to cervical cancer, and realize that some of the audience are not radiation oncologists, but this is a very curable cancer, even when women have advanced stages of cancer. So this is an MRI of a woman's uterus, a large cervical tumor. These patients require a combination of daily radiation for 5 weeks, chemotherapy, and brachytherapy. And brachytherapy is referred to as internal radiation, and some of the speakers may be discussing this as well. But once this tumor shrinks after daily radiation, patients are asleep. We put these applicators in the gynecologic tract. This is an example here of an intravaginal photo where tandem in the uterus, these ovoids at the top of the vagina. But now most of us have segued to what's called hybrid applicators using MRI guidance. It's very sophisticated technology, but we put these catheters into the cervix under MRI guidance. What happens is each of these devices is attached to a machine, and a little radioactive pellet goes down each one of these devices. It takes about 10 to 15 minutes to treat these patients. And the end result is we can administer these very conformal doses over a short period of time. Data is out there. The cure rates are higher when we use image-guided brachytherapy with MRI. Unfortunately, the US, we've seen a decrease in brachytherapy utilization rates. And so as former president of the ABS, and I'm going to finish up here in a moment, we've launched an initiative to try to train 30 brachytherapy teams per year over the next 10 years called 310. And so we've finally gone live with this. There's been delays. This was just published in the Journal of Brachytherapy. But our goal is not only to do this within the US, but to also work with the International Cancer Expert Corps. ABS has an international committee. You'll hear just some terrific work coming up in a little bit of efforts ongoing in Africa. But as we're trying to get these services going in Africa, we have some of the same issues in the United States for disparate populations. So I'll end there, and thank you very much for your time. Sorry for the technical difficulties at the beginning.
Oh, great. Thank you. Thank you, Dan. That was great to understand. Even in a resource-rich country, we have such great disparities. Our next speaker is in Australia and does work in Africa and is based in Philadelphia, Surbhi Grover. But I'll introduce her, and she's going to come on through a video that she pre-taped for us, given the time zone differences. So Dr. Grover is a radiation oncologist at the University of Pennsylvania's Abramson Cancer Center. Her research interests include racial and ethnic disparities in cancer care and outcomes, HIV-related malignancies, and implementation and upscaling of prevention and treatment programs in low-resource settings. Since 2011, Dr. Grover has been engaged with the University of Pennsylvania Botswana Partnership and is currently serving as a gynecologic cancer clinic director and oncology consultant at the Princess Marina Hospital in Botswana. So now we're going to have her video for us.
A second.
Hi, good morning. Thank you so much for having me today at the session. I'm Surbhi Grover, and I'm a radiation oncologist at the University of Pennsylvania, but I'm primarily based in Botswana, which is in Southern Africa. And my primary job in Botswana is to take care of women with cervical cancer, as well as do research and training for providers, residents, and researchers in the region. So I wanted to share today some of my experiences working there and taking care of women with cervical cancer in sub-Saharan Africa. So cervical cancer is, although we don't see it very commonly in the developed world anymore, in the high-income countries anymore, but it is still about 50% of our clinic in Southern Africa. And part of it is because of lack of screening programs for cervical cancer, but the other aspect is because of the high prevalence of HIV in that community. It is very unfortunate that a lot of our patients, despite being very young, median age of our patients is in their 40s, they present at very advanced stages, primarily stage 2B or stage 3. And what that means is for their treatment, the only treatment is actually chemoradiation. But despite coming in at that advanced stage, not everybody is able to access treatment at the right time either. There's so many delays in the system, from actually getting the biopsy to actually having the biopsy result and then being referred to the right place for receiving treatment. And in this process, a lot of women either end up having even higher stage disease or and end up losing their lives because they're not able to get appropriate treatment. So all of this goes to say that we have a lot of work to do. We have a lot of work to do. This disease is impacting women who are very young, who are very productive members of their society. And we actually know how to prevent this cancer, and we actually know how to treat this cancer. The issue is we need the right tools implemented in these countries where they don't exist. All the evidence exists. We know exactly what we need to do in order to improve the outcomes and bring access to treatment. And here the answer is, in some way, quite simple. We need to have the right systems to provide radiotherapy. Well, first of all, we need the right systems to bring in women early in their treatment screening, coming in earlier stages. And for the women who are coming in advanced stages, we need appropriate access to radiotherapy. We need to make sure there's appropriate equipment that works. There's appropriate staff to treat these patients in a timely fashion. So I am involved in several projects in implementation science, clinical care, quality improvement to do a lot of that. In Southern Africa, we're actually building a consortium of very enthusiastic clinicians as well as researchers in the region to work on several of these issues. So I'll stop here and I'll pass it on to Dr. Rohini Batia, who's a resident at Hopkins, and Rohini has worked with me since she was a medical student and has been really passionate about radiotherapy and care delivery in low middle income countries and women's health. And she is now a radiation oncology trainee at Johns Hopkins University. And she will, after finishing her training, is going to continue on some of the work. She's actually worked with me in Botswana and spent time in the clinic there. So I'll stop here and pass it over to her. Thank you.
Great, thank you. Always nice to hear from Surbhi and her long work in Botswana, which has really been building capacity. Next, as she mentioned, this is the other half of the dynamic duo of Surbhi Grover and Rohini Batia. I'd like to introduce Rohini, who's, as Surbhi said, a third-year resident in radiation oncology at Johns Hopkins. And she has a strong interest in working to mitigate disparities in access and quality oncologic care in resource-limited settings. She graduated with a degree in epidemiology from the University of Rochester and was a Fulbright Nehru Scholar in Delhi, where she investigated predictors of tobacco use among women. She's worked with Dr. Grover since 2015 on a variety of projects, including quantifying delays along the patient care continuum in oncology. She's worked with Multidisciplinary Women's Clinic in Gaborone, helping to test a pilot new smartphone application and refine clinic workflow, and is currently working on understanding the uptake of hypofractionated radiation therapy in low resource settings. So welcome, Rohini.
Thank you so much. Can you guys all hear me okay? Okay, wonderful. I'll share my screen. Okay. Well, thank you so much for the panelists and for the panel for talking about this very important topic. I won't go too much into the statistics. I think that we've discussed them, but I want to highlight this map right here. Looks at the estimated number of new cases in 2020 for cervical cancer. And I think cervical cancer, as we've seen, is an example of a cancer type that truly hides global disparities. This map also reflects, the mortality map looks similar, indicating that most deaths from cervical cancer occur in low and middle income countries. And we know that with proper prevention and screening, this is in large part a preventable disease. And we also know that radiotherapy is a mainstay of curative treatment for this disease. So geographic regions that lack the prevention and screening and therefore see more advanced disease is a significant problem and a place for focus for research. I'm going to focus specifically on Botswana. Botswana is a country of about 2 million people in Southern Africa. It has one of the more stable economies in Africa. It's supported by the coal and the diamond mining industry. And the current health expenditure is about 6% of their GDP. The two pictures here show the government-funded public hospital, Princess Marina at the top, and then the private hospital, Gaborone Private Hospital. And the reason this is important is because, as we've discussed, radiation therapy is a mainstay of treatment for locally advanced cervical cancer. But the only radiation facility is housed at the private hospital. So for patients in a government-funded healthcare system to get radiation, there are certain steps that they need to go through. The government puts out some paperwork that needs to be filled out so that a patient can then go and receive radiation at the private facility. In Botswana itself, in 2020, among both males and females, cervical cancer and breast cancer take up about a quarter of the total number of new cases of cancer, which is quite staggering. And among females themselves, cervical and breast cancer are about half of all the cancers that we see. So why is cervical cancer have such a high prevalence in Botswana? And it's a multifactorial reason that we could spend a whole hour on and talking about. But one of the reasons is that infection with HIV actually increases the risk of having a persistent HPV infection. And HPV is a necessary cause for cervical cancer. So this co-infection with HIV and HPV can cause an increased risk of the development of the disease. Cervical cancer in Botswana is the leading cause of death. Over 2/3 of these cases occur in HIV-infected women. And Botswana is a country with one of the highest prevalences of HIV. Among women 30 to 49 years old, HIV prevalence is about 50%. Now, huge strides have been made in the country, and the availability of antiretroviral medications is high, and the uptake of those medications is high. So most patients that we're seeing in Botswana now with cervical cancer have pretty well-controlled HIV. There's a higher CD4 count, but it doesn't take away the fact that this co-infection of these two viruses can cause for an increased risk of the disease. When we think about global health disparities, I wanted to kind of put this framework out there, and we've seen this with Dr. Formenti and Dr. Petereit, that there are different types of disparities at each level of the patient care continuum, from risk factors and screening to access to quality treatment. Then when a patient finally gets to treatment, supporting them through that treatment. And finally, after they've completed their treatment, what's their follow-up like? What's their quality of life like? And how can we support them as survivors? Just an example of a study that we've looked at, the age of cervical cancer diagnosis we've seen is younger in countries with a higher prevalence of HIV. So in Botswana, what we saw was that this blue line looks at the age of diagnosis among patients who were HIV positive, and the orange line looks at it among those who are HIV negative. The most common age group at presentation for cervical cancer was 35 to 44 years old in those who had HIV. And among those who are HIV negative, it was 65 to 74. And what we know is that once a patient is diagnosed with cervical cancer, that process took about 10 years to form. So that screening should have happened 10 years prior to the diagnosis. And so data such as this were really important in changing the World Health Organization guidelines for screening. And what we've been able to do is say, for women living with HIV, we should start screening at an earlier age, at age 25. And instead of screening every 5 to 10 years, let's screen every 3 to 5 years. And this type of research, I think, helps to identify subgroups of populations that are at risk and can really bring them screening and tools to help mitigate the disparities that we're seeing in disease. Access to quality treatment, sort of the next step of the continuum. This is one of my favorite graphics, and it is from Dr. Walter, an Anderson model of delays. So it asks patients from every step of the continuum, if you can remember a time where you felt an ache or pain, what prompted you to seek medical attention at that point? Once you seek medical attention, how long is it till you get a diagnosis? And once you get a diagnosis, how long does it take for you to start treatment? And so we looked at this model in a patient cohort of cancer patients in Botswana. And there's different types of delays, and I'll briefly touch on them, but a help-seeking delay, as we can see here, is from the point of time of perceiving a reason to discuss a symptom with a healthcare provider to a first consultation with a healthcare provider. And what we found was that there was a huge importance of a social support system. So females were actually less likely to experience help-seeking delays. And one of the hypotheses was patients with larger families were less likely to seek help, were less likely to have help-seeking delays because they had a support system that could act as caregivers to children if a woman needed to go to a healthcare facility. And so we start to see that there are characteristics in society and at the individual level that impact a patient's ability to seek treatment. Treatment delay is the average time between diagnosis and treatment, and it was about 155 days. 50% of patients had greater than 3 months from the date of diagnosis to treatment. And just want to let that sink in for a while. We don't always see these numbers here in the States. And patients with breast cancer were more likely to experience delay. Why this is an ongoing question, and again, multifactorial likely, but important to document so that we can start to ask these questions. One of the most incredible things I think that Dr. Grover and her group has done in Botswana is the Multidisciplinary Clinic. So in organizing a radiation oncologist, a clinical oncologist, a nurse manager, and pathologist to look at new patients with cervical cancer, all under one roof, and to come up with staging and treatment. It allows for convenience on the patient side, but also allows for evidence-based decision-making in real time. And we help with the paperwork then. Earlier, I mentioned that radiation in Gaborone occurs at the private hospital. During these MDT clinic visits is when we're able to fill out that paperwork and really start the patients on this journey if they are to get treatment. In a paper published in JGO, Dr. Grover's group documented the change and the impact that MDT could have. The time from biopsy to radiation start before this clinic was 108 days. And the average time after the start of the clinic was 39 days. So really showing you the impact of what coordinated care can do. This is just an example of the clinic. This is Mama Nare, who's our wonderful nurse manager. And this is what a normal clinic morning looks like. Patients will come with records. And I always found it so wonderfully impressive, the knowledge that they have about their own health because they keep their own records and folders. And if you ask any of these patients, they're able to show you, here is my last CD4 count, here's how I'm taking my medications. And it's really a testament to both the physician and the team here, as well as the patients in the success of this. This is an example of the treatment facility for radiation that we have in Gaborone. And finally, these last two steps of support through treatment, follow-up, and survival, I think really are the areas that more research can happen. So specifically, what are the toxicities during treatment? What is the sexual health and quality of life of patients receiving chemoradiation after a cervical cancer diagnosis? And how do we support patients who are survivors? And I think these are ongoing questions. I apologize that this slide didn't come out properly, but I wanted to just give a shout out to the Botswana UPenn partnership and the IEA for their ongoing efforts in really helping with this. And I'll stop there. Thank you so much.
Great, thank you very much, Rohini, giving us like a picture of what it's like there to treat patients. Next, our speaker is Dr. Manjit Dosanjh from CERN. So she's had a long career at CERN, which is also the acronym for the European Organization for Nuclear Research based in Geneva, where she has served as the Director of Medical Applications and played a key role in launching the ENLIGHT network, which is the European Network for Light Ion Hadron Therapy. She has a PhD in biology and is on the faculty of University of Oxford, and she has served as a mentor and advisor for many students across the globe. Her work has included many initiatives to expand access to care for those in low and middle income countries and for advancing career opportunities for women in science. She's a member of the board of directors of the International Cancer Expert Corps and also serves on as a project leader for something you'll hear more about from her called Project Stella. So welcome, Dr. Dosanjh.
Thank you, Donna. Thank you, everybody, for giving me this opportunity. Let me see if I can share. Can you see this? It's okay? Can you see?
Yes.
It's not full screen yet. Yes.
Okay. All right. So I'm going to, well, you've heard from our colleagues in previous intervention, shall we say, the challenge that we are facing in disparities in cancer, and not just in developing countries, but also in US, not just in US either, high income countries, there are disparities even within those countries with, depending on what's available in terms of care, detection, diagnosis, and treatment. So one of the things I wanted to try to show a little bit globally is where we are and where we could go depending on some ideas of technologies and mentoring and developing workforce. And so you've already heard this from all of our previous speakers, of course, but what I wanted to point out is, yes, you know, cancer is a huge global challenge globally, not just in developing countries. And in 2020, 19.3 million, 10 million deaths. And of course, this number is increasing, as Silvia had said. And it's really sad to see that 70% of these deaths are occurring in low and middle income countries. But I wanted to point out, since today's panel is about cervical cancer and breast cancer, is that in 2020, 2.3 million breast cancer cases and 675,000 deaths, okay? That's much, much better than it was 20 years ago, but still a huge number. But the thing that's even more surprising is that for cervical cancer, the number is about a quarter, the incident, but the deaths are half of breast cancer. So this is 50% almost women dying. And the thing that to highlight again is 9 out of 10 deaths for cervical cancer and 7 out of 10 breast cancer and LMICs. So out of all of those, the huge number that's happening in low-income regions, also within high-income countries as well. So this is really the starting challenge. And as Silvia and our colleagues have said, radiotherapy is an essential part of a cancer treatment, okay? Sorry, it seems to have a mind of its own. And however, only 10% of the patients in low-income regions have access. So if you look at this global access map, you can see that, of course, high-income countries have a lot of access to radiation therapy, but then we have other regions, particularly the ones in red and orange, are really challenged. And the continent that's really suffering the most from this challenge is Africa. And it seems to be that for Africa is mortality, cancer deaths, energy, internet, disease, COVID access, vaccines. And so what we have done as part of ICEC is to start with focusing with the continent that seems to have the worst challenge, shall we say, and see if we can try to look at steps which could help to improve the situation. So, by the way, there have been great strides have been made in fight against cancer, but as has been already emphasized by previous panelists, access remains a challenge. There's a critical shortage of radiation therapy equipment in rural communities as well, as Dan has showed, as well as at MICs. Families are destabilized, communities are disrupted. Even if you have access to radiation therapy treatment, I mean, even in the UK, the average commute time is 2 hours to get treatment. So you can imagine in countries which are much larger than that, and they do have machines, how much time and disruption that's caused to everyday life and to the family units. And the lack of access to basic cancer prevention and treatment in emerging economies, because we always look at economics as well as what's available, leads to almost 46 billion loss in revenue. So perhaps one can think about that rather than worrying, just saying, yes, health is really important, but let's see how much economy we are losing as well. So maybe using a double faceted approach. And in Africa, and I'm going to come back to that, there is more than 1 billion people in Africa, and they almost have no access. And this is really tragic. And I've been collaborating a lot with Nigeria, and I wanted to choose Nigeria for 2 reasons. The population in Nigeria is over 200 million. And in the last 2 years, now they have 7 machines. They had 4 before. okay? But if I look at the comparisons of, I'm sitting in Switzerland, we are a population of 8.6 million. We have 72 machines, okay? Nigeria has a population of 200 and it has 7 machines. And if you think about the US, where Silvia showed, how many machines we have, 300 million population, 4,000 machines, okay? So there are huge disparities. And what can we do, not just for cervical cancer and breast cancer, but in global health challenges? What can we do? And if you start then looking at GNP, and I've done global sort of national product per person, because it's very difficult if you're going to compare Switzerland of 8 million with Nigeria of 200 million. So I think it's important to also look at income per person as well. So here is population sizes and mortality. I mean, this is really, really tough. Very nice if you're sitting here, but how do we make all of these go down here? And this is one of the challenges, because we have to talk about global equity, global health, global access. That's what we need to do. So, and the current need is 5,000 machines. And Linacs do offer the state-of-the-art treatment, but they cost more. They are more complicated to use. They are labor-intensive to operate and maintain, and you need experts, which are in a short supply, unfortunately, always in South Dakota, as well as Botswana and Mozambique, and wherever you have less access. So how do we do all of this? So Donna alluded to this Project Stella, smart technologies to extend lives with linear accelerators. So Project Stella is a unique collaboration involving the best minds, the physicists, the medical doctors, the accelerators, but most importantly, the users at the grassroots as well, because if you're going to try to solve a global problem, we need input and collaboration with global stakeholders, okay? And this is really, really important. And the goal of Stella is to enable cancer care through innovative technology that's both disruptive, uses artificial intelligence, and is centered in mentoring, because machines don't treat patients. People do, as we've just seen from our previous 4 colleagues, okay? And so our network of Stella addresses the injustices through mentoring and disrupting the disruptive new technologies. And you've already seen Surbhi here together with Rohini and Norman Coleman, whose brainchild ICEC is, of mentoring to bridge the care gap, partnering, and hand in hand working on developing new approaches for treatment, which can really make a long sustainable difference, okay? So how do you look for solutions? I'm coming from CERN, we're looking for the Higgs, we're looking for these things we don't know which they might exist or could exist, and how do you do that? And so, the first thing to do is define the problem. And then you try to gather the information as to how you're going to be able to, what the problem is and how we might be able to address the problem. So, and then identify the challenges from the people who live them day to day. We're sitting in Geneva or New York or wherever you are, can't see what that is unless you go there. And this is why people like Rohini and Surbhi and Oni and others, which we are collaborating with, are such key to this, solving this situation, to really experience it day to day with them and saying what, really makes a difference. So create specifications from the machines that could work with improved design, which they would like to use, not what we think they should use, but which they would be able to feel comfortable with using, and find a solution and make the solution available to everybody, okay? So what we did was we partnered, and we started with Africa because it has the country which has the biggest challenge to access to radiation therapy, is we collaborated, and we were very fortunate that we were able to collaborate with all 28 countries, there are 29 now, that had a radiation therapy machine, and ask them, what are their challenges, what works, what doesn't work, and then also compare with our high income country partners of US, Canada, Switzerland, and Jordan as a middle income country, which has amazing progress with King Hussein Center, which had nothing 20 odd years ago, and now is state of the art, compares with almost anywhere you would think that is the center, whether it's Cornell or whether it's UCL or whether it's generally in Geneva. So what we did was we looked at the data, and and it's really sad. Not only some of our countries in Africa don't have machines, but the machines are always broken down. I mean, it's really sad. You have very few machines and they don't work all the time, okay? And I mean, just look at this. So all the blue stuff is high income, all this is in Africa. So not only do we need machines, we want to make sure those machines function and they work and they don't break down. So then we looked at, so why do they break down currently? So 3/4 of the time they break down because something breaks down and they don't have a spare part. And to access spare part, they have to go somewhere because it's not locally available. They don't have an engineer, and it's really challenging. And you might have heard, I think it was last year in the middle of COVID in Zimbabwe, when this young woman talked about the fact that she was having breast cancer treatment, but all 4 machines in Zimbabwe were not working, and the parts couldn't get there because they had to come through South Africa. And she was trying to see what happens if you don't have treatment for 4 weeks or 2 months. And she said she couldn't find data what happens if your treatment stops for that long. So, this is the challenge of having functioning machines, power, electricity issues, which we just take for granted, but not just for running the machine, but if we are talking about software and artificial intelligence, so we're talking about networking. If you don't have electricity, you don't have access to that. And then software challenges. So what our survey told us was that machines breaking down is a big challenge. And this chart, just like the one where I showed you about the GNP, this is the effect of breakdowns on deaths. So what we want is a solution which is working, easy to use, is robust, is not expensive. We're looking for a dream, of course, okay? And, and everybody can afford. And at the same time, we are going to be able to face the problem of lack of qualified personnel, because the machine should be so smart, they need less professionals, okay? But we will never be with 0 professionals, but less professional people. So ICEC, as well as working on a technical design for a machine, is looking at multiple fronts for capacity building, for mentorship, from twinning, leveraging communication tools. By the way, COVID has shown us that even though it's really sad that we can't see people face to face, there are a lot of things we can do with the power and the technology that's available. So, use these for enhancing education and training, as well as one-to-one sustainable relationships. I think these type of things are not like helicopter, short episodic visit, go there and fix it and come back, because it just doesn't work. So we need use the tools, but also build sustainable relationships on a long-term mission, and all in the spirit of shared mission, while helping to develop the career paths of people like Rohini and Surbhi, but at the same time, training people in developing regions and giving the best patient healthcare. I mean, that's what we are thinking about. So the ultimate goal for Stella, as I said, a robust, modular, reliable, simple to use machine. I mean, why can't we have one of these, Easy to use, who would have thought that we could have it 20 years ago, okay? So, and reducing the cost, operating all of these. And I mean, ultimately what we want is to increase the number of patients which are being treated. So build expertise and capacitance. And this sort of big global problem cannot be solved in isolation. It really needs global collaboration, global people, and people who are really worrying about bigger challenges. And whether it's you're talking about cancer treatment, or whether you're talking about environment, or whether you're talking about climate change or energy, all of these require this sort of vision and people working together. And I have to say, Rohini and Surbhi have mentioned Botswana, but when we had our workshop with our collaborators in Botswana, it was really the changing, a change point for us, this collaboration with Stella, of power of seeing and understanding the challenges together and looking for solutions together. I think this is what's really important, is credibility, trust, sustainability, and really caring about a long-term future. So thank you for giving me the time.
Great, thank you, Manjit. Now we'll open it up to questions. And I can begin with one that's come in. There's a lot of comments on health disparities in younger women. How about health disparities in older women? Maybe the clinicians could comment on that. Silvia or Dan?
Well,
Yeah,
I mean,
so, sorry, go ahead, Dan.
I mean, it's even probably more pronounced for us for all the screen detectable cancers for older women, breast, cervix, colorectal, lung. I mean, we run the gamut. I mean, obviously cervical cancer affects a younger population. And for the guys, it's the same thing out here with prostate and all the other screen detectable cancers, except obviously breast and cervix.
Yeah, so we certainly don't want to underestimate the burden of cancer in the middle-aged and elderly. That is striking. I also want to stress that in many cultures, the mothers are in the fields and the grandmothers take care of the children and maintain the village going. So, those women are certainly crucially valid and important, and the same for men. So we don't want to underestimate this. It's just that the data we have access to are the direct, at least for the study we conducted, was a direct impact on children younger than 10 when mommy dies. And, it's fascinating because it's an impact that goes across socioeconomic status of countries. Even in Denmark, if the mother dies, there is a sizable and detectable increase in the mortality of children younger than 10. So is this really this crucial dependence of the offspring from the mother? But having said that, the cancer burden is for everybody. And as you can see, for instance, lung cancer is somehow genderless. You have, having access to radiation machines for lung cancer is key, is crucial. So, and it's not just the impact on mortality, is in reducing the burden of the disease, because dying with untreated cancer is burdening an entire society, an entire community.
Great. How about a question came in on the incidence of cancer in children in Africa. So maybe Rohini, you could comment on that.
Sure. I would have to look at the specific stats for it, but certainly there's a different type of childhood cancers that we see in Africa. For example, Burkitt's lymphoma is related to EBV, and it is much more prevalent in Africa than we see in the US. In Botswana, there is a partnership with Baylor Children's Health, and they have a pediatric oncology center through that partnership. But we don't treat pediatric radiation patients in Botswana. We send them to South Africa because it is such a specialized method of treating children. And I think underlying both this childhood cancer and also elderly cancer is something that we're starting to talk about in the US, but it has a probably very different composition in low and middle income countries, is financial toxicity, and understanding the impact of treatment on families in that realm as well. So thank you for the question.
Right. And then another question on disparities. Oh, go ahead.
Can I just say something about the challenge of children? I was going to say, we, ICEC, are also collaborating with Global Hope with David Poplack, and they are concentrating on children. And the experience at the beginning, when he was saying, is that they started working in Uganda and many other countries, and perhaps if Norm is on the line, he can say something. At the beginning, there was hardly anything at all for, as Rohini said, children require a specialized access, and often they have to be anesthetized in some of the other challenges. And it's difficult enough having a machine, and then to have all the support work to do that is not easy. And by the way, and I found that also in some of the work I've been doing in the Balkan countries, they don't necessarily have the possibility to treat children. So it's a really important question. And there are, of course, childhood cancers in Africa too, but the challenge of treating them is even more challenging, so to speak. And you need the specialist support, and you need good collaboration to be able to send patients, kids, and so on. But there is, the Global Hope is doing a great job in really concentrating on pediatrics and children in cancer. I could put a link up there if you like.
Great, thank you, Manjit. And through the International Cancer Expert Corps, Duke has a partnership with
yes.
Tanzania and Bugando.
Yeah, so Nina has just put that up. Thanks, Nina.
Great. Another question was on disparities of people with disabilities. What is what you hear and experience about that to the panel?
Maybe Silvia or Dan?
So I'm not certainly an expert on that, but I know that is really country specific. You know, the one thing that I've learned from Dr. Balogun is that when she worked with both Armenia and Gabon, she was struck by the fact that they had ramps for wheelchairs, but there are other countries where, you know, having a disability is considered like a form of shame, and you know, it's not even easy to deal with the disability itself. So I think is once again, it would requires a collaborative approach in understanding the culture and addressing the needs on the territory in a sensitive way.
Dan, I don't know if you think probably special considerations for disabled and special needs patients getting radiation therapy.
Well, I mean, the American Indian population out here, they tend to have a lot of significant medical comorbidities, diabetes, heart disease. There's a lot of them serve in the military. So I would say a number of them have some form of disability, but you know, we do have a pretty comprehensive approach so we can take care of their needs, but it does pose some unique challenges.
Mm-hmm.
Dan, I have a question for you. For when there are disabilities, and also for Silvia as well, I mean, how easy or difficult is it for the person to first get the diagnosis and have access to going to the hospital and the places?
Yeah, in at least in my superficial experience, and I'm really interested in learning from Dan, it depends so much on the ongoing psychosocial support of the subject with a disability, and is really very culturally sensitive. If there is strong psychosocial support, the entire family is really harnessed to support the care, the cancer care of the patient with a disability. If for whatever reason there isn't, it becomes an extra barrier to access and to treatment.
Yeah, for us, that's a huge issue. And Rohini, I loved your slide about the time to events, and we see that all the time, and not to throw Indian Health Service under the bus, but they're underfunded. And we've looked at that for several years, all these time to events. Why does it take so long to go from symptoms to seeing a provider to a diagnosis to treatment? And so when we had a really, one of our initial protocols for the first 5 years is when we did these screening events, we consented them to follow them till the point that they were screened. And if it was a normal screening, then we were done. If it was an abnormal screening, then we would push to get them diagnosed. So for example, with our big project right now is LDCT project, and Indian Health Service does not cover the cost or nor offer LDCTs. So it's kind of bizarre, but here you have a population that has a high smoking rate, 95% mortality rate from lung cancer. And so we have been in the communities facilitating these screenings. We have grant money to pay for the LDCT. It's a short-term solution. And then we had a lung cancer screening symposium, and Dr. Coleman was one of our participants, but he wasn't able to come because of all the restrictions. But the goal is to influence IHS policy at a national level. This is something that you need to cover because it's needed in your community. But it's one of those ongoing dilemmas that absolutely drives me crazy.
Rohini, would you like to add anything?
No, I think that's excellent. That delays model is something that I think that the adoption of that and understanding each point of that time model and the factors associated with it would sort of change the way that we can form interventions. And I really believe in asking patients what they need before we start anything.
Yeah, I like to add to what has been said by Dan and Rohini. We conducted a study in collaboration with a public hospital in Mexico City, whereby we study the lag from early detection of patient feeling a breast mass and going to a primary care doctor to the care, to the first intervention, biopsy or segmental excision or mastectomy. So the first intervention that will trigger the care. And while we learn that there was more locally advanced disease, of course, and more palpable diseases, but there was a time interval of close to 2 months from symptom to access to the doctor, and that could be somehow addressed with education. But then there were 6.6 month average time lag from the primary doctor. So the doctor knew the woman most likely had breast cancer, but delayed to an average of 6.6 months to take the patient to confirm the diagnosis with a biopsy. And then once the biopsy was done, there were like a couple of weeks before the treatment was done. So really an opportunity to implement an intervention to educate. So the primary doctor who knew the family, who knew the patient, didn't want to get the bad news, kept hoping that was not cancer, so delayed for half a year, the intervention and the treatment. So by studying these time courses, you really have opportunities to work with very, good colleagues we have in the community in these countries and show the impact and trying to resolve from the very first, moment of access to the treatment, those gaps. So definitely a big collaboration that could be put in place.
And just to add really quick on what Dr. Formenti said, and Dr. Petereit had mentioned a nurse navigator. And I think patient navigators in this space are such crucial people, because this is complicated, right? There's a lot of specialists involved, there are a lot of tests to be done. And we're very lucky in academic medical centers here in the US that those exist in a multidisciplinary clinic format. We have one person dedicated to getting the pathology slides, the imaging, organizing all the specialists to discuss each patient. That ideal access is not afforded to everybody. So what are ways and who are people we can get to talk to patients and say, okay, the next step is an MRI. Here's how you can go and get that. How do we coordinate that? And I think the nurse navigators are invaluable.
Rohini, I have a question for you. I mean, we don't see much HIV where we live, but how do you manage those patients with all the myelosuppression, with concurrent chemo-rads, the brachytherapy? And this gets really complicated. You throw 50% of these women are HIV positive. So what does that look like?
Yeah, it's a great question. There's been a lot of work in understanding the impact of chemoradiation on patients with HIV. And what we've discovered is that if CD4 counts are about 350, if they're well controlled, they do just as well as their HIV uninfected counterparts. And that's a really important conclusion, because surveys were done among radiation oncologists here in the US even that said, oh, maybe I wouldn't give them as high of a dose if they were with HIV because of worry of toxicity. And the work that Dr. Formenti has done in the lab, I think many years ago, has shown that with HIV, there is higher risk of toxicity. But as we have been able to better control the disease, that risk is a little bit less.
So your treatment interruptions are okay. I mean, they're not profound as long as your counts
Yes, and in Botswana, the CD4 counts are well controlled. It's a very well controlled HIV population. In those that are not well controlled, I think the first step is always getting them on antiretroviral medication and starting from that perspective. And Dr. Formenti, you've done a lot of work in this area. Happy to hear your thoughts.
There's a question also from Sheila. Donna?
Let's see.
About disparities of cancer care amongst Black women and white women in the US.
Okay. Maybe Silvia could comment on that.
Yeah, so absolutely, it remains a challenge and a huge challenge in this country. I want to quote the work of Melissa Davis, Bonetta Davis, in fact at Cornell now, who has demonstrated that there are genetic predominance of certain SNPs in the dark gene that is an innate immunity pathway gene. So there are genetic predisposition for African-American women of African-American descent to have triple negative breast cancer and more aggressive triple negative breast cancer. With that said and considered, and she's studying, and she has beautiful studies to really understand the implications on how the disease, the rapidity of the disease, the onset of the disease, and somehow resistance, at least in a proportion of these women, to treatment. So of course, we have to understand the ethnic determinants of the outcome of the disease and the genetic determinants. But what remains very clear is a problem of access and adherence to care that really reflects often other barriers, socioeconomic barriers, concerns about employment, having insurance or fear about being burdened by bills if they don't have insurance, because the cost of healthcare without insurance is very high, even if there are laws in place that will assure a woman with breast cancer gets emergency Medicaid and should have access to care. But definitely a crucial evidence that while the decrease in mortality in white women has been steady, every year 1% of mortality goes down for Caucasian women, that decrease, that curve is different for African-American women. There's been a decrease, but not as significant. And certainly for women with a subset of breast cancer called triple negative breast cancer, the mortality is pretty flat. And I think very much an issue to address and to learn from that focuses on our own disparities, even in larger New York.
I was going to say, Sheila, if you want to follow up, please you can use your microphone. You have access. All of you have access to ask questions.
Yeah. I think I do. Can you hear me?
Yes, we can. Thank you.
I asked the question because my mom died from ovarian cancer, and it was very disturbing to my sister and I, the care that she got from her primary care physician, who she had been going to for, I guess about 20, 25 years. And she kept complaining and having symptoms, and the doctor just brushed her off. And by the time it got so severe and she finally sought care from another physician, she was diagnosed. But that was after about 2 years complaining to her physician. So we know that there is a disparity, but why Black women or women of color are not taken serious when they complain about certain illnesses and things that are going on in their body, and they are brushed off, which is another reason that I feel Black women and women of color do not get the care to take care of medical concerns at an early stage, thus preventing it from happening. Not only is access and money, but just the brushing off by doctors when Black women complain about having a certain illness or needing treatment.
So Sheila, you're putting the finger on an incredibly important point. Ovarian cancer we didn't cover in this talk is called the silent killer. Is because of the occurrence around menopausal age and postmenopausal, is often presenting with very difficult to pin down symptoms that often are associated with menopause and postmenopause. So across ethnicities is misdiagnosed and often, diagnosed after months and years of symptoms. So for the time it's diagnosed is already stage 3 or stage 4. Having said that, I think across subsets of the population, and as you know, it's difficult to organize based on ethnicity because we all are somehow mixed ethnicity, but you're absolutely right. Women of color have a later diagnosis and probably they're dismissed more. And again, a lot of confounders, socioeconomic, but it could be much more than socioeconomic. So there are differences. And as you pointed out, this neglect then reflects on the trust on the institutions of entire groups, because that's particularly hard. I see, much to my dismay, in breast cancer that somehow the navigator and the patient coordinator and so on doesn't follow through enough often with minority women the way she does with women who do not have language barriers, or they look more like her. And so there is a component of really needs to be addressed about these disparities in attention to care, in just how we welcome patients into the system, how we listen to patients. That should be learned early in medical school.
Yeah, and in the US, the spotlight has been shining on this issue, and hopefully we'll begin to see more attention on the part of providers and institutions to address the things that Silvia spoke about. Another question was, are there cultural superstitions associated with female cancers, from Hania White?
I can touch briefly on it, at least. When we did our survey of the delays in Botswana in women, we looked at fears and cultural associations and some superstitions. And there's no one arching cultural superstition, but what I think is important to understand is women can be embarrassed about symptoms, especially in gynecologic cancer. So bleeding is a common symptom, and women may not want to tell anybody about it or talk to people about it. Or if they do, they'll talk to, in Botswana, there is, and they're traditional healers, and they may go to a traditional healer before going to a hospital. And so things of that nature, increasing awareness of what the symptoms are and the importance of following up in a medical establishment if those symptoms occur, and the awareness of that are important.
So I want to make two brief comments. One thing I learned from Kathy Foley. Kathy Foley had a large initiative, I think supported by the Soros Foundation, to look at palliation of cancer in children, particularly across continents pretty much. And she was reporting on really these differences in reaction of the family and the village to a child with cancer. And in some cases, having a child with cancer, not only was the lack of access to care, but it became a label for the family have done something wrong. So there was exclusion of their family will have to leave the village and get into the jungle to put a hut in the jungle and be discriminated upon having a child with cancer. So there is magic thinking and kind of these issues to address, and again requires cultural anthropology background and capacity to handle them in a competent way, but they do exist. And I think even the data I showed before about what's going on in Mexico City in a public hospital, in a big town where of course there's a lot of information available. Sometimes the barriers are this belief of the doctor doesn't want to be the bad person that tell the patient you have cancer. And that is something within our reach to educate and to address and to explain the impact of that delay.
Dan, you must experience some specific challenges on perceptions with the population you serve, American Indians.
It's really interesting what Rohini had mentioned, because there's a strong history out here with medicine men, traditional healers, and we actually partner with them. And so it's not uncommon that, because we invite them, we've engaged them. So currently we're in year 3 of a palliative care project, and Katrina Armstrong, who's now the dean at in Columbia, New York City. So she relocated from Boston, but this is a partnership with MGH Harvard. And so the first phase of our palliative care project, there's no palliative care in the reservations, is doing these talking circles. And we engaged a lot of people, including the traditional healers / the medicine men. And so really to understand what their perception was on, there's no word for the palliation in Dakota. So we renamed our project to Living Well with Chronic Illnesses. And so that came from the community, but more specifically, the GYN world, because this is another thing that just continues to baffle me. Why are these women presenting with late stages of cancer? And one of the barriers is They know these are relatively small communities. They know the providers, they're embarrassed. And especially if it's a male provider, they prefer not to get a pelvic exam from that person. So what we find is the state workforce are female nurse practitioners and PAs who they trust, but still there's this issue of privacy and, you know, gynecologic cancers. So the thing that kind of struck me is there's a lot of parallels with what you're doing, what you're seeing, Rohini, in Africa and what we're seeing in our population. I mean, yes, there's differences, but there's a lot of similarities as well. So we'll have the medicine men tell their patients, you need to go to the cancer center. We can work together. They're not mutually exclusive. They can be synergistic.
Great, thank you. Another question came up on COVID and delaying treatment and screening. We know this is a big problem. What are you each experiencing in your settings on COVID-related delays?
We were, you know, New York obviously was hit hardest from the big cities, but I would say all my cervix patients had COVID. We treated it regardless. I mean, I can't believe I didn't get it. I lived in a sea of COVID for about 2 years. So there was ways to get around it. If they were profoundly ill, we could do the brachytherapy, but yeah, it was, I think we're all trying to figure out what to do with this. We could put
So
them on
it's-
for 3
Yeah,
months.
the same for New York. You know, all our hospitals in New York kept going, and the Department of Radiation Oncology was open throughout. What I think is the impact, and we start seeing the effect, is that most people delayed their preventive care, and any measure of early detection got postponed, whether it was colonoscopies, mammograms, PSA exams and so on, or bronchoscopies, and as a result, we're seeing a more advanced disease. And compared to last year, we just reviewed the data. We have more node-positive breast cancer, larger tumors. So we shifted we went back, we went backwards in terms of the advantage that early detection, which is not gigantic, but is a sizable advantage, for instance, in breast cancer, has made in terms of certainly organ preservation, conservation of the breast, as well as a small impact on mortality, but a sizable impact. And we went back like to, pre-mammograms data and started seeing more palpable tumors and more tumors with nodal involvement. Ned Sharpless had modeled this, as predicted and modeled this effect in colorectal cancer and breast cancer. And in fact, we're pretty much following the prediction, and that will reflect on increase in mortality because of COVID. By the way, COVID also had increase in mortality of other diseases like cardiovascular disease and neurological cause of death. So definitely an impact. I cannot even start imaging how, COVID pandemic, it seems like Africa is a little bit more protected from COVID, but, if it were to get more serious, it will have even more disastrous effects.
And treatment change recommendations were made. So in radiation, we have fractions in how we deliver radiation. And during COVID, the guidelines were, if you can hypofractionate, which is give it in a shorter number of fractions over a shorter period of time, we would recommend that. So that prevented patients from going to the hospitals as often and reduced risk exposure.
Yeah, I think we're at time. I wanted to thank the panelists for the great presentations and discussion, and the participants, and especially to thank Batia from CERN, who supported all of us in pulling this together. So thank you very much for joining us, and hope you tap into some other sessions connected to this Commission on the Status of Women. Thank you, everyone.
I was just going to say one thing, Donna, for all our participants as well. I mean, we've recorded this, so it will be available somewhere with a link, YouTube or somewhere, okay, or ICEC's website, actually, most likely. So if people are interested in having a look at that, that's where it will be. Thank you again.
Great. Thank you, everyone.
Thank you.